Okay. Good morning and Happy New Year. And welcome to the Cook County Health Board meeting today on Friday, January 30th. I'm calling the meeting to order, and I'm going to ask the secretary to call the roll. To call the roll of attendance, please.
All of a sudden, I feel like I'm in a Smashing Pumpkins concert.
Did that good?
A lot of reverb.
Am I on? I'm going to do a quick sound check with the remote attendee. Brian Alston, can you confirm you can hear me? Brian Alston or Letty Close, can you confirm that you can hear us remotely?
We can hear you. It's a little faint.
Thank you so much. Okay, that's the roll call. I apologize. Director Bott?
Present.
Director Green?
Remotely present.
Director Harrington?
Present.
Director Kim? Vice Chair Lowry? Is absent. Director Masuda Barnett? Present. Director Ryder?
Ryder is here.
Director Robinson?
Present.
Director Sorrell?
Present.
Director Stain? Here. Director Webster Cross? Is absent. And Chairperson?
Present.
You have a quorum.
Thank you, Madam Secretary. I'm going to need your help on this one. So I'm asking for a motion to allow Director Sorrell, Directors Green, and was there someone else?
I'm not sure if Director Webster Cross is going to be remote, but we can do the motion later for her
Sure.
if she connects.
Okay, so I'm looking for a motion to allow Director Sorrell, Director Sorrell and Director Green to remotely participate in this meeting as a voting member.
So moved. Second.
I have a first and second. Is there any discussion? Hearing none. All those in favor, signal by saying aye.
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 All those opposed, say nay. Motion passes. We'll move to item 2, which is employee recognition presented by Dr. Eric Markaitis, the CEO.
Thank you, Chair Garza. Good morning, directors. Morning. We'll start, as always, with our new hires and welcome Susan Edrelin, Senior Director of Laboratory Medicine, Jason Jong-Seok Lee, Pharmacist Manager, Shalandra Jennings, Senior Manager of Complex Care Coordination, Community Care. And we'll shift to recognizing some of our team members who earned promotions over the last month or so, with Elizabeth Weber, Associate Chief Operating Officer, Health Plan Services, Denise Holman, Manager of Family Planning Services, and Roshonda Boyd, GME Operations Manager. Some recognitions and announcements. This first one, I want to just give kind of a bit of the backstory. We have reinvigorated our Good Catch program, so we kind of once a month go out, and some of the good catches that are highlighted, we'll go and recognize our team members. This was a multi-team member effort, and before I dive into this, as always, if you're in the room, please stand so we can recognize you through all of the various recognitions. But in this situation, we had a patient come to us last fall, and of course want to recognize the entire team who was involved. We had a patient come to the hospital with injuries and was accompanied by an older male. And the care team was informed that the patient was an adult. The patient needed to have some urgent procedures and possible surgery. However, when the team tried to get informed consent for treatment, the patient had difficulty signing the paperwork. The patient also didn't have an ID or a phone. Also wouldn't provide staff with information about their family. So at that point, the team brought in psychiatry and social work for some help. And after review and consultation, it was determined that the patient was in fact a minor runaway and was apparently being trafficked by the male who was with her. So the appropriate agencies were involved and the patient was removed from that situation. We also, just earlier this week, had a press conference with President Preckwinkle and our partners at the Sheriff's Office and the State's Attorney's Office, as it just so happened that January is also National Human Trafficking Prevention Month. So we wanted to be sure to recognize the team for their diligence in recognizing and for their tenacity in standing up for this patient's safety. So thank you to Dr. Avula, Laura Kozak, Bobby Pollard, Dr. Pulakidis, Dr. Trin, and Dr. Watts. Congratulations. Thank you. Thank you, team. Okay, so congratulations to our Stroger Hospital's Neuro ICU and Burn ICU for being awarded the Silver Beacon Award from the American Association of Critical Care Nursing, the Beacon Award for Excellence. The award represents the average scores from 3 modules: patient outcomes, nursing workforce, and work environment. Congratulations, team. Yeah. Congratulations as well to Dr. Pierco, our Associate Chair of Medicine, Dr. Hoffman, Associate Chair of Hospital Medicine, and Tracy Everett, Associate Director of Nursing Emergency Services, for being selected for a Chef Service Excellence Award. The Chef Service Excellence Award recognizes outstanding healthcare leadership teams in the Chicago area, and the award is going to be celebrated at the 50th anniversary annual meeting on March 18th. Congratulations, team. On January 21st, CCH was joined by state and local leaders at the Greater Chicago Food Depository to raise awareness about upcoming changes to SNAP and promote CCH's Food as Medicine initiative, including on-site food pantries, public education campaign, medically tailored meals, and screening and referrals. Next slide. Cook County Health has also been providing timely information to the public about potential harms of the federal health care cuts. On January 5th, Congressman Krishnamurthy joined Cook County leadership and hosted a press conference at the Bronzeville Health Center to highlight the impact of the expiring enhanced ACA tax credits. And on January 6th, CCH gathered with leaders from state and local governments to call for renewed investment in federal health care programs and encouraged current Medicaid clients to stay tuned for more information about upcoming eligibility changes. Cook County leaders held a press conference, this was last week, on the eve of Maternal Health Awareness Day, to announce the launch of the Healthy Beginnings program at Cook County Department of Public Health. The Healthy Beginnings program is now delivering home-based nursing care and wraparound support to pregnant individuals and their infants across suburban Cook County to reduce preventable maternal and infant illness and death. Congratulations to our infection control team for their leadership in guiding Stroger and Provident hospitals through a recent audit by CMS's Clinical Data Abstraction Center. Stroger was recognized for 100% compliance for health-associated infections, and Provident achieved a 91% compliance. Congratulations, Dr. Lovell. And congratulations to Stroger Hospital for being recognized by Q-Source End-Stage Renal Disease Network with the Golden Q Award that honors dialysis facilities that demonstrate outstanding performance in areas aligned with CMS quality improvement goals. The hospital's dialysis team has been presented with the Respiratory Shield Award for achieving at least an 80% vaccination rate for pneumococcal pneumonia and influenza vaccines this season, as reported in EQRS. Congratulations. Congratulations as well to our Stroger Hospital team on the grand opening of the renovated cafe, Violet Cafeteria. The refreshed space is now providing a streamlined visitor and staff experience, including mobile ordering and 24-hour meal solutions. That's great. That's it? Okay. I think we have one more slide. Do we have Steve Harrow?
Do you want to do that now?
Yes, yeah. Why don't we do that and close out? So as a last piece, there's been a lot of movement at the federal level and a risk of an additional government shutdown. I did see some articles come through yesterday that may may be potentially slightly less likely, but we thought it would be good to have one of our senior policy advisors in DC join us remotely. Steve Harrow is with us to give us kind of an update of the lay of the land. Steve?
Thank you, Dr. Makaitis. Good to see you. Pleasure to be with the board. I appreciate you inviting me to speak. I will be quick, but I'll also be available for questions following. As you've been reading and has been indicated that by Dr. Makaitis, we are kind of running out of time with regard to funding the federal government. So there are two bottom lines I'm going to share. I think I'm going to share with you then the details. The bottom line is that we are heading toward a partial shutdown tonight at midnight, because we do not have a legislative path forward just yet, which I'll explain. But that partial shutdown, the second bottom line, though it will affect us, we are not heading toward a long-term shutdown in a way that we were, CCH, affected during the 45-day shutdown in the fall. A lot of our equities, which are in the Labor, Health and Human Services bill, will get done in time before we start to see a major financial effect. For many issues like disproportionate share hospitals and 340B, the timing of those payments will not fall within the window of this shutdown. So what is going on? We have passed 6 appropriations bills so far. There are 12 total. There are 6 remaining, one of which is the Homeland Security Appropriations Bill, which is the most controversial. The other 5, which again includes Labor HHS, that we truly care about, CCH, are non-controversial and can pass if they stood on their own. Yesterday, a deal was cut between Senate Democrats and the White House to take those 5 bills and pass them on their own, because the way in which the congressional process worked over the last few weeks, the remaining 6 bills were married into one, sent over to the House to the Senate. A deal was made to vote separately on those 5 and then do a 2-week continuing resolution on Homeland Security. As I'm sure folks know, Homeland Security is controversial in the wake of what happened in the terrible killing in Minnesota last Saturday. And so Democrats wanted to put some legislative safeguards into the bill regarding actions by ICE going forward. So a deal was struck. They were going to vote on it last night, but then one senator raised his hand and made an objection over an interesting policy with regard to senators whose phone records were subpoenaed by the Jack Smith investigation, that senators could sue for up to $500,000. That provision was stripped out. Senator Lindsey Graham said, I want that provision back in. They couldn't vote. So we're kind of still nowhere right now. There's no vote scheduled. Funding runs out at midnight tonight, and the House of Representatives is not in session until Monday. So barring some type of miracle of physics and timing, we will have a partial shutdown through the weekend. Where I see this going, Dr. Makaitis, is there will be an agreement to vote on this 5-bill package. It will probably happen sometime over the weekend or early next week, and then the House will pass it, and the president will sign those 5 bills into law probably by Tuesday or Wednesday. And then Homeland will be 2 weeks. So all that to say, we're heading toward this problematic reality, but I do not believe it will have a long-term effect on our equities with regard to what's coming for us and what we work with the federal government on. So I'll stop there in the interest of time. If folks have any other specific questions, I'm ready to go.
Steve, thank you very much. Any questions? I just want to say Heather's head's going to explode if she's been a legislator. Okay. Thanks again, Steve. If there aren't any questions, I will pass it back to you, Chair Garza.
Thank you. I saw Letty was on the agenda as well. Is there anything?
Yeah, I just confirmed. There's questions. She's happy to jump
Okay,
in.
got it. Thank you. We'll move to item 3, public testimony. Madam Secretary, are there any speakers registered to provide virtual or in-person testimony, or have they sent any written testimony to be included into the record today?
We did not receive any registrations nor any written testimony.
Okay, thank you. We'll move to item 4, board and committee reports. And that'll be item 4A, minutes of the December 19th, 2025 board meeting. I will present those and ask if there are any corrections that are needed. That doesn't appear to be. So then I will ask for a motion to approve item 4A, the board meeting minutes of December 19th, 2025. Can I have a motion, please?
So moved.
Thank you. And we have a second. Is there any discussion? Doesn't sound like there was any corrections. Any discussion or comments?
Chairman, may I be added to the
Yes,
roll,
sir.
please?
Yes. For the record, we will add Vice Chair Lowry to the board meeting today. Okay. All those in favor, signal by saying aye.
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 Opposed? Okay, the motion carries. We'll move down to item 4B, minutes of the January 16th. I'm guessing that's 2026? Should be.
Yeah, did I have the wrong date?
It says 2025.
Yeah, sorry.
It's rare that I catch something like that, but it's good when it happens.
I knew it was gonna happen.
Yes, minutes of the January 16th, 2026 Quality and Patient Safety Committee meeting, and I'll turn that over to my colleague, Director Bott.
Thank you, Mr. Chair. Quality and Patient Safety Committee met on Friday, January 16th at 9 a.m. Committee approved the following action items, which are included in the minutes. Approved 2 Stroger Hospital Division Chair reappointments. Approved Stroger and Providence Hospital medical staff appointments, performance changes. Committee received the following reports, which are included in the minutes. Operation Excellence Dashboard, Goals and Tactics, Regulatory Report. Next meeting of the committee will be held Friday, February 20th at 9 a.m. There are no other questions on the minutes that may be presented to the board in consideration at this time. Thank you.
Thank you, Director Bott. If there are any questions, I'll ask for a motion to approve item 4B, the minutes of the meeting of the Quality and Patient Safety Committee of January 16th, 2026, which include approval of the following items. 2, Stroger Hospital Division Chair reappointments and the Stroger Hospital and Providence Hospital medical staff appointments, reappointments, and changes. Can I have a motion to approve, please?
So moved. Second.
I have a first and a second. Are there any comments or discussion? Hearing none, all those in favor, say aye.
Aye.
Aye. Opposed? All those opposed? Motion carries. We'll move now to item 4C, minutes of the January 8th, 2026 Finance Committee meeting, and I'll turn that over to Director Ryder.
Thank you, Mr. Chairman.
Yes, sir.
The Finance Committee, Thursday, January 8th at 10 a.m. The committee considered the following action items, which are included in the minutes. We conditionally approved 9 contracts and procurement items. Number 4 is pending review by contract compliance. On the screen, you'll see the contractual requests from the Finance Committee meeting, whose fiscal impacts are greater than $1 million, which are highlighted for your information. We received and filed grant award related items. The committee received the following reports, which are also included in the minutes. Report on minority and women-owned business enterprise participation. Report of 5 emergency purchases. Report of preliminary November financials. Monthly report on our agency reduction plan. The next regular meeting of the Finance Committee is scheduled to be held on Friday, February 20th at 11:30 a.m. If there are no questions, the minutes are being presented for the board's approval at this time, Mr. Chairman.
Thank you, Director Ryder, for the summary. And before we get back to that item, I want to ask for a motion to allow
Just if you wanted to state for the record that Director Webster Cross is present here.
Okay, you just did that, but I'll do it again. Director Webster Cross is present via Zoom, so we've acknowledged that.
So she's
Oh, she's here. Sorry, you are here. Sorry.
I
Okay.
wrote that down wrong. I apologize.
Okay, here. Yes.
Thank you.
That's going to confuse me more. Thank you, Deb. Welcome.
It's the code.
Yeah. Okay.
It's starting to feel like one of my meetings.
Yeah, exactly. Getting out of control here. Okay, so we need a motion to approve item 4C, the January 8th, 2026 Finance Committee meeting minutes, which contain the following action items: conditional approval of the contracts and procurement items pending review by contract compliance, and receiving and filing of the grant awarded related items. I'm asking for a motion, please.
So moved.
Thank you. I have a second. Any discussion, comments? Okay, hearing none. All those in favor, say aye. Aye.
Aye.
And anyone opposed, say nay. Okay, that motion carries. We'll move now to item 5, action items, contracts and procurement items. None are being presented this month. So I feel like we're ahead of schedule here. We're moving right along. So we're up, yes, item 6. I'll try not to slow down with my report. I do want to say this, though. I had an opportunity to attend the Healthy Beginnings press conference last week, and I know that Alex does a great job of getting information out to the board on various events that are happening, such as the events that Dr. Makaitis covered. I know we're all busy and you have full-time life and work, and any chance that you can make these events, I think you really get a keen insight on the great work that the staff and the leadership are doing in the communities, like my experience in Blue Island, along with Director Harrington, who also attended. So this is really just trying to encourage, there's an opportunity to get out there and really see the work that's happening, because it's great work. It's tremendous work. I know we get the highlights, but a whole different feel and experience when you're at the event. So that's my report. I'm going to turn it back over to Dr. Makaitis for item number 7 to complete his report, which I believe is the divisional report.
It is. Thank you, Chair Garza, and we have the privilege of hearing from Dr. Sharon Irons and Octavia. So Dr. Sharon Irons is our medical director with ambulatory, and Octavia Rollins, who is our executive director with ambulatory.
Good morning.
Good morning. Thank you for having us. So we're just going to kind of jump right into our ACHN presentation here and start with quality, safety, and experience. So the latest development for ambulatory operations is that we're aligning to support our 2026 value-based care quality goals, which includes preventive care and chronic disease management. So upcoming priorities for this year include, number 1, increasing annual wellness visits from our 6% baseline to 35% of our impaneled patients that are traditional Medicare patients in primary care, and we want to do this by the end of 2026. We want to continue to improve our hypertension control, and we've been doing really well with that in the latest years. Hypertension control, meaning blood pressure less than 140/90, and we want to increase from 55% to 65.7% by the end of the year. We want to also decrease the percentage of patients with hemoglobin A1C greater than 9, which really connotes poor diabetic control. So we want that number to go down from 37% down to 34.9% by the end of fiscal year 2026. So again, we'll be monitoring all of this, access limitations, visit completion reliability, which obviously directly impact both quality and our value-based performance.
I have a question. What constitutes a wellness visit and how many do we make?
Yeah, so a wellness, so as you can see, we're only at a 6% baseline. So although we do prevention visits, right, or an annual visit with a physician, history and physical, a wellness visit is different, and it doesn't even have to be conducted by a physician, although a physician can be involved in that visit. So what we're really looking at is determining social determinants of health for that patient, any quality metrics that need to be addressed, such as hypertension, diabetes, chronic conditions, vaccinations. All of that is really going to be looked at in that annual wellness visit. We're really looking at what type of care management support in that visit that the patient needs. So really it's a way of just kind of journaling out, what do we need to do for this patient this year to help with prevention and chronic disease any kind of social determinants of health.
So it's an in-person visit at a clinic?
It's in person, but a great portion of it could also be a telehealth visit.
Thank you.
You're welcome.
And there's a question on this, is that, if I understand it right, both an impact on outcomes, identifying, potential clinical issues earlier, prevention, health promotion, and there's a financial impact in terms of reimbursement.
Absolutely,
Medicare wellness
absolutely.
visit,
So, of course, with pay for performance or our value-based care contracts, if we're closing those care gaps, making sure we're getting the blood pressure under control, the diabetes controlled, prevention, as we stated, they have their mammogram, are we doing PSA screenings? All of that is being addressed. So as we close those care gaps, we're getting closer to, doing better with our pay for performance and our value-based care contracts.
If I can add there,
That
so there's
answers
that
it.
direct kind of the financial, right, that we get for doing the additional piece of the visit, because you can bill for the annual wellness as well as the, the reason that they're in, you can do both in the same visit. However, when you look at the data, those who get annual wellness visits compared to the population that doesn't, their total cost of care is significantly lower as well.
I'm sorry, so that's interesting. So you say those who complete the wellness visit.
Yep.
So my question is, what is the branch from that actually gets you the lower cost?
That's exactly what Dr. Irons is talking about.
Yeah.
You're doing colon cancer screening, you're managing blood pressure, you're doing mental health screening, you're doing all of those things, and it's a reason to make sure you're doing it once a year for the patients who you're seeing for the annual wellness visit.
So does the data state that if they get an annual visit, there's a tendency for them to do the follow-up? Because that's the real piece of the puzzle.
Well, that's right, because you're going to have staff, nursing staff, you're going to have physician support around this, social services, mental health support. So when you identify an issue during your annual wellness visit, then it can be addressed and it can be assigned to the appropriate care team member to work with that patient. So now you're closing those gaps over the year.
So there is a tendency that if they complete that, you can get them to return for the other activities that are needed.
That is correct.
Ah,
That is correct. And that's exactly what we want.
Okay.
So if we're evaluating a patient in an annual wellness visit and we determine, we need to address their breast health, we need to address colon cancer screening, the fact that they're having transportation issues getting back and forth from the visits, and we start to address those things, then that's going to really, improve the patient's quality, the outcome, and also it's going to improve our financial health as well.
Okay, and I'm gonna ask this question again because I want to make sure I'm hearing this correctly. So you have hard data that shows that.
That shows if we do annual wellness visits so there is data out there, absolutely. I don't have it in front of me right now.
I'm just
But yes.
No, because, we're at 6% right now, and that's part of this population health transition initiative is so that we are aligning and, under Dr. Irons' leadership, right? That's the whole thing. The whole point of this is that we're doing this better, right? So.
Oh, I'm a believer.
Yeah.
But the question always comes, can you show it with the data? I'm
So-
not asking you to.
No, that's
but-
okay, Director. I'm very happy to follow up with you because, this has been looked at for years under value-based care and having, accountable care organizations. So absolutely, that data is out there to show that if you're impacting prevention and chronic disease management, that it's going to be a good bottom line financially and quality-wise. I'm happy to provide you with the information. I just don't have it with me now.
I would welcome that.
Okay.
Okay, the other question I have is under the hypertension control and the A1C. What are the levers that you plan to move in order to move those numbers?
Okay, so I think you're speaking to the interventions that we're doing around that. So I'll tell you, we have been working with the hypertension for quite a few years now, and I want to say we've really put a lot of effort in it, starting with the pandemic. At that time, we had about 32% control across the system for patients who had diagnosis of hypertension, and today we are at 55%. So we've done a lot of great work with that. What have we done? We've partnered with the American Heart Association, the American Medical Association. They've come in, they've helped train our staff around appropriate and how to appropriately take blood pressures, which is a big deal. They've helped us with quality improvement in terms of how we help patients with their own self-management, having blood pressure monitors at home, and we want to eventually move to remote patient monitoring so that we are actually getting data from patients in their home setting coming to our electronic health records. So we're working on that as well. So there's a lot going on the ground, you know, to impact the hypertension. Diabetes as well. We have a HEDIS group. We have champions that are specifically addressing that. We now have point-of-care diabetic machines in every clinic, which we didn't have before, which means a simple finger stick and you can see how the diabetes is doing. And you can make real-time decisions and begin to treat that patient. So we're looking at that. We put together chronic care management appointments with the RNs for specific education for those diabetic and hypertensive patients. So it's not just the physician or provider working with the patient, it's the entire team. The patient comes back, they bring their blood pressure log, their blood sugar log, they get education, they get help with self-management. So all of that is actually impacting the patient.
Thank you very much.
You're welcome.
Question, this is great. Where do the wellness visits actually occur? Explain just that process, please.
Okay, thank you. So up until now, with our meager 6%, they were happening in the clinic generally, and mostly with our geriatric team, right? But now we are developing this out, and in fact, we're starting a pilot with 2 of our clinic sites, which we intend to expand out and scale out to all clinics by April 2026. What that will mean is that patients will either come into the clinic or have a telehealth visit or some combination thereof, where we're reaching out, we're addressing all the issues we talked about: prevention, social determinants of health, chronic disease management. And so we can now see, we have a diary for the patient in terms of how we need to deal with them during the year. So these visits are going to be done by nurses to begin with. We're just starting this process, and it's a pilot, but we believe that the RN personnel are the ones to really work with this process and partner with the physicians, but they will actually do the visit. And they will bring anybody else into the visit that is needed, such as a social worker or a mental health specialist or whoever else is needed to make sure that we're working with the patients closely.
Follow-up question. I heard colon cancer screening, which is very important. Early detection is key. And,
Yes.
and I say that not just based on my education relative to healthcare, but my own life experience. Are we screening for any other cancers other than colon?
Yes, so we are now a partner with Wellvana, which is an accountable care organization for us. So we are focusing on breast cancer screening as well as the colon cancer screening. Those are metrics that we have to impact as an agency.
You know what, I don't want to keep you stuck in that, so I'm going to
Okay.
jump out here.
Maybe somebody needs to mute. I don't know. Was that a question or just noise? Okay. All right, so the other, so we're also, just as an organization, in terms of our HEDIS metrics, we're also looking at cervical cancer screening. We have we've really started looking closely at cervical cancer screening over the last year. And we've made some positive impact on that. I think our baseline of patients who qualified for cervical cancer screening was about 41% when we started, and now we're at 55% of our patients, and that's just over about a year and a half. Again, the colon cancer screening is, and we look at it across the board, but now we're actually being much more deliberate about it. We're looking at this in our value-based care program. So that will be impacted. We're also doing more prostate cancer screenings as part of the birthday program we put in place. And breast cancer screening is doing very excellent in our system as well. And we continue to work with that. And so those are the real big 4 that we have been focusing on.
So the birthday health screening program, focusing on mammograms and prostate.
And prostate, that's correct.
That's the result of my resolution. So as we go
Yeah,
forward,
absolutely.
please provide data to me so I can know and determine just the usage,
Yes.
relative to this opportunity.
Yes.
And then based on your expertise, the efficacy of what we're doing, that would be very helpful.
Okay, absolutely,
Thank you.
Commissioner Lowry. We will bring that data back to you If I had known, I would have had it with me today, but we are making some definite positive impact on both the prostate cancer screening and breast cancer screening. I think you'll be happy about it.
Deb has all my contact information going back to the 80s, all right?
All right.
We'll get together.
So you have the cervical and the breast, which if we know the populations that we serve in the Black and brown community has a major impact.
That's right.
So my question is, those that are coming in, you're able to impact, but there's so many that are not. So is there any type of thought as to how we can reach them?
Yes, so I think as part of that birthday program that we're doing, we are open to the community at large. So not just patients that are within the umbrella of Cook County Health now, but, you know, there's been press conferences and information going out. We have provided a general telephone number that folks can call to get set up for their breast screening or their prostate screening. So that's part of what we're doing to kind of impact at large. And then I'm going to look over at Dr. Joshi if he's here somewhere. He and I and County Care are working and partnering together to begin to impact cancer screenings as well.
Yeah, what would really be interesting to look at is longitudinally what this means.
Yes.
Because you can take a snapshot in time, but if you look at it over time, you can see whether or not any of this has made a difference. Because a lot of times we take a snapshot and it's what's happened right now. But over time, and I would assume that if you catch something early, you don't get the same outcomes over time. But we have data that probably will help us better understand that and understand if our interventions and the things that you're talking about actually work.
Yes, absolutely. You're 100% correct. Most of these metrics we have been monitoring over time. Like I said, the breast cancer screening we have. Colon cancer screening is something that we're really starting more intense focus on now. And we've followed everything, but now that really intense focus is now happening with this value-based care program. So, and I'm happy to come back at any time to kind of present out how we're progressing over time.
Ted, given the data that you were talking about with the wellness visit, what is the issues or the challenges, barriers that the reason the 6%? I'm just curious.
Well, I'm going to say I think the first reason is because we haven't really put true focus on it, right? It's really been more so the patient comes, they see their provider, their physician, their APP, and they're the ones that are really doing the bulk of the work in terms of taking care of the patient and doing the orders and all of that. This is another arm that we're adding to our population health and value-based care project, where we want it to be someone other than the physician. We want a huge team approach around these patients, and that's why we believe we're going to start these with RN visits, and we're going to have other staff. So it's really, just to really answer your question, it's about now putting intense focus on this area. So I fully believe that we're going to see some much better numbers by the end of this year. We're starting this.
Thank you.
Yep. Okay, do you want me to proceed with the, okay. So we have a few more slides to get through. We can actually go to the next slide. So this slide is on workforce. So a workforce development review has identified opportunities to better align staffing models with clinic demand and productivity. And as part of this review, ongoing vacancies in select frontline and support roles were confirmed as a contributing factor influencing our throughput. So ACHN ended fiscal year 25 with a 21% vacancy rate for our support personnel. And you can see the breakdown here: clerical, ophthalmic techs, medical assistants, and nursing. So our priorities include implementing APP workforce optimization and specialty care to expand capacity and reduce physician bottlenecks. Reduce vacancy rate from 21% to 17% for those support roles by the end of fiscal year 2026. I don't know if you want to add anything to
Yeah,
that.
absolutely. And so ACHN has been partnering with HR on our recruitment tactics or strategies to kind of help develop really unconventional ways, but yet staying within our guardrails to fast track our employees within our organization or our candidates. We know that we have a ton of candidates applying that will love to join the CCH family. It's all about the recruitment strategy. And so what we focus on to help get down to the 17% was our accelerated hiring process. It eliminated additional layers and sometimes in being the manager to do all the screening and the interviewing will prolong the onboarding time frame. And so we know that these jobs as a clerk was very standard. And we trusted our HR partners to be able to review and screen all of the applicant's resume and fast track that applicant by accelerating hiring without having us interjecting into that process. It yielded a favorable return for us. As you can see, we were able to decrease from 21 to 17%. However, it did not solve our opportunities, as you can see. And so our next strategy will be our hiring fair. ACHN will partner with the next department to tag along to help improve our gaps in our PID vacancy rate. Of course, we have the hospital that leads a lot of those initiatives with their hiring fair, as we just concluded an ER and an OR, but ACHN can tag along to kind of help address some of these vacancy rates here as well. So that partnership with HR is crucial to our success in ACHN. In addition to, we have a weekly touch point with the Associate Chief of HR to discuss additional strategies, opportunities for improvement on both sides so we can mend the relationships and move forward to get our candidates in a rapid rate.
Okay, next slide. So our transformation and growth, latest developments is that we have established a baseline coming into this year of that we have 117,000 roughly engaged and affiliated patients in primary care. Our upcoming priorities are to increase engaged and affiliated primary care patients by 3% by the end of 2026. So getting a little over 120,000 there with a stretch goal of 5%, 123,100. Other priorities we're working with is providing access in our Far North clinics. The Arlington Heights Clinic will open an imaging center and provide immediate care services, target September 2026, to give patients walk-in access when they can't see or for whatever reason can't get to their PCP, and just to offer extended evening and weekend hours. We also want to continue ongoing efforts to promote growth and awareness of our immediate virtual care program, Express Care, which includes expanding patient education initiatives around this, just creating awareness that this program is there for patients to call in virtually, and they would have an APP engage them in the care that they need virtually. Expand primary and specialty care access capacity across ACHN by optimizing provider and APP templates to better align visit types, acuity, and demand patterns. Monitor and improve slot utilization to ensure available capacity is fully leveraged and access opportunities are not lost. Any questions on that one? Okay, great. Fiscal resilience, the latest development is improved coordination between operations, finance, and revenue cycle to our access, documentation, and reimbursement. Upcoming priorities for this year is to exceed our budgeted volume expectation in primary care, which is 236,744 visits, and specialty care, 419,000 visits to improve access and support volume-driven growth. Advance revenue cycle documentation initiatives to improve reimbursement accuracy and timeliness, and expand ambulatory capacity to improve access and support this volume-driven growth. That's pretty much it. We'll be monitoring, any kind of revenue leakage from delayed or incomplete documentation and access constraints limiting growth. Questions?
Yes. on your revenue increase, so you're looking for your CPT codes, correct? That is one of your sources?
I'm going to have Octavia take that question.
Yes.
She's my operational partner.
Understand, okay.
The CPT code drives, right, the activity that's happening within the space.
So which actually is the bigger drive, the CPT codes or the pay for performance?
So that's a great question. Poor performance will have an impact on our revenue, right? We know that it's important that we're not causing downstream revenue impact to the institution. And poor performance will lead to readmission. Poor performance will lead to hospital stay, length of stay, right? So it's taking a step back and understanding the impact of poor performance. In addition to that, specialty drives a good portion of our ambulatory revenue. And so in the specialty arena, which is the arena that I support, I have several areas that contribute procedures into that space, will allow us to enhance our revenue activities. In addition to that, we have areas within the specialty space where we're performing not only procedures, but we're also incorporating some of that radiology component into that space of the work that we're performing. So I think it's a multifaceted approach. Yes, we need to do what we do and do it well. Because if you don't do it well, you will see that in the ED. You'll see it in the inpatient side. But we also have to ensure that we're staying competitive in the market and offering the services that our colleagues are offering, which is very standard, right? So if I'm dermatology and I have a patient that has eczema or a patient that has, this is an eczema, for example, I want treatment. I want to be able to come in and get some laser treatment to help me because it's a psychological effect to me. Is it life-threatening? No. Does it have a weight on my mental? Yes. And as a patient, I'm coming to you with a concern. I'll have my dermatology visit, but yet I'm looking at myself in the mirror and I'm dealing with some other psychological issues because of the dermatological issues that I'm having. And so as an institution that can help with some of these disease management, we offer a procedure that will yield a higher reimbursement versus just an evaluation and management visit. But then that's how you have to look at the specialty space. What are the work that I'm doing and performing in this space? What are the additional services that I'm adding that will yield a reimbursement and better quality of life? And what does it take to do those things? And how do we do it very well so there's no impact into downstream revenue?
Now, this is interesting because I wish we had a whiteboard now. This is fantastic stuff right here. Because if we start looking at the whole idea of the preventative,
Absolutely.
catching stuff early,
That's right.
and now we're going to make references back to the PCP, which is you.
Mm-hmm.
And then if there's something found, we're also going to go into your specialty group.
Yes, sir.
Now, here's where the interesting comes for me. If we look at that, what's happening there, how does it impact over on the other side as well?
Mm-hmm.
So does it help, does it hurt, or does it just change places?
So I think one of
Okay, when you say impact Stroger, do you mean inpatient, or what are you speaking of specifically?
Absolutely, inpatient, because inpatient.
I love it because it looks like Eric wants to maybe answer some of that, so.
Well, I think just it's one of the areas that we're focusing on. We talk often about optimization as one of our pillars, right? Performance improvement, process improvement, that's absolutely the area we're focusing in, is how we tighten up those referral patterns and ensure that when somebody is identified in the primary care space, needs specialty care, and then needs something at the hospital, that we're keeping kind of that network tight and that it's staying with CCH.
Okay, so the next question is, how does that break down when we look at the people who are covered with insurance versus those who are not covered?
Well, you still, go ahead. We're going to provide care no matter what.
That's understood.
Right?
We're talking finances now.
Absolutely, absolutely. The programs that we have within the institution to provide our patients with CareLink and, any affordable plans, payment plan, there's a lot of work that's being done behind the financial aspect of it. And we're not turning any patient away regardless of their inability to pay. We're going to look at that patient and we're going to treat the patient and coordinate between primary care. And I think that's the key. That care coordination is the key. There's no longer that silo. It's like, I'm specialty and you're primary care. There has to be some handoff.
Yes.
Go ahead.
That's right. It's a continuum, and if I understand, maybe a part of the angle of your question is we have a payer agnostic approach when we're dealing with our patients. But what we do understand is that we also have value-based care contracts, we have pay for performance, and so our payer population is important, right? Because our mission is to take care of everyone, but we have to have the finances. Look at that.
Keep
This
the
whole
lights
thing
on.
working. Right.
Lights on, absolutely.
Right, exactly. And so what we also understand is that we have to look at our patients who are self-insured or not insured at all or care linked, because if they come into the hospital, that's going to cost money, right? And that's money that's not going to be paid for by our payers. So obviously, we want to have a payer agnostic approach across the board for all of this. Now, getting back to, I think what part of your question might have been, is that when we're addressing prevention, when we're addressing chronic disease management in the outpatient setting, when we're partnering with specialty in the ambulatory setting, we're keeping patients out of the hospital. The better we do that, the more we keep them out of the hospital, and the less finance, right? The less financial risk we have by keeping folks out of the hospital, out of the ED. So part of the work we're doing in value-based care, and a very large part of it with our care management teams, is looking at that. How do we impact high utilizer patients that are in the ED, in the hospital quite often? Right. We need to put good care structures around them so that their care is in the ambulatory setting or at home, as opposed to in the hospital. So it really is all a big umbrella together.
So, and that was part of the thinking behind leaning in on contract adjustments so that we are more aligned in how we're getting paid. There's additional data transparency where, we're on one EMR, we've got other EMRs kind of out in the community. They don't all talk, right? So as we lean in on the contract realignment, we have better claims experience. We see those patients that are attributed to us. We can see, we may know that they came to the ER once or twice this last month. They may have been across the street 2 times that way and 2 times that way. We have we have very little kind of transparency into all of that happening, right? So with the claims experience, we can have a better insight so that Dr. Irons and the primary care team and the care management team can really see, like, maybe we're missing something. We probably need to identify, this patient is a high utilizer. It's not just with us, it's out in the community. And then to the question, Dr. Irons said it, right? This is payer agnostic, and we want those processes in place so that we are focusing on upstream intervention and prevention. And, for the uninsured patients, really conceptually, we're at full risk for those patients. Everything all the care we provide to them is full cost, right? So if we're talking about a $2,500 colonoscopy versus a few years from now having to spend $130,000 treating stage 4 lung cancer or colon cancer, right? That's a huge difference. So, how do we front load that and make sure that we're doing as much prevention as we can in the people who don't have insurance, right? The trick is going to be getting them to engage in their care, because we know when people lose insurance, they tend not to come in for those preventative visits, and they end up kind of waiting until, there is advanced disease. So that's going to be the next thing that we have to figure out.
And that's why I want to put out what maybe seems to be controversial, but not necessarily. If you really look at understanding how that patient is getting paid is actually important. Because if they are not covered by any insurance, then you want to increase your efforts because of everything you just said. If we can actually get that care to them, then we will reduce the cost and make that person healthier. Because there is that tendency, if I don't have any money, I'm not going to go until basically the roof is falling in.
That's right. You're 100% correct. So that's why the payer agnostic approach is very important across the board. Agreed. Yep.
Okay. Which again, I'm promoting to understand what is the social dynamics of that person so that you can get them appropriate care. Because if I come through there, I have insurance, I'm going to need some support, but not the same support as the person who doesn't have the insurance, who's trying to stay away, but yet they still need the same support that I have. And they're not going to get it because they feel as though they shouldn't or they can't.
Yep.
That changes the dynamic.
Yeah, I don't know if they're intentionally trying to stay away. They believe that they're healthy, but they're not.
Not necessarily. There's some folks who know I'm sick, but I can't afford to go to the doctor, so they don't go. But now when I get so sick, now I'm forced to go, and where I go is to the ED. Am I correct?
Yes.
Yeah, but a lot of my early work was around blood pressure. And blood pressure, and hypertension are asymptomatic. You don't have symptoms till there's something serious that's happening. So people feel they're healthy, but they may not be healthy.
There are people who have that perspective, there's no argument about it.
Right.
But there are others
That's
who
most
know
people.
that they have a problem, but yet do not do it.
And they
I
wind
love
up in
this,
emergency.
conversation between you two.
Yeah.
This is
Yeah,
fantastic.
it is, but we need to.
If I could just intervene and say this, that is why we have care coordination teams, right? So anyone that somehow gets engaged with us in any kind of way, we do understand that those patients who are CareLink or they don't have insurance, they might not utilize the system as much as we would like them to in the right way that we would like them to. But the care coordination team will be looking at the complexity of the patient. Part of the complexity is they don't have insurance. Another part is they might have multiple chronic diseases. Another is this patient is, very poverty stricken, cannot even get to the clinic because of transportation. So there's a whole bunch of factors to look at across payers, across those who are not insured, put it together under a care management program, and it impacts the highest risk patients. So we are now putting into our EHR a way to calculate the complexity of a patient or a group of patients so that we know how to align care management around higher risk patients or higher utilizer patients. So that's part of the work that we're doing with the value-based care. Yes. Okay, you're smiling.
Okay, are there any other closing questions? Yes, Dr.
Yeah,
Bob.
just, and we can talk about stuff. The last point about expanding ambulatory capacity to improve access for volunteer, could you say more about some of the strategies you're considering, or that's in progress?
Oh, yeah, absolutely. First and foremost is looking at our current state with our scheduling utilization. What does our slot type utilization look like? Do we have some wait slots? What does the capacity look like for our providers? And so maximizing on that opportunity, really showing our scorecard to our division chief and coming up with a plan on how do we improve the capacity with our providers. Secondly, your APP optimization. What does the structure look like? Are they complementing the services? Are they adding to? Are they independent? That also matters. What does that utilization look like? And so you put together the scorecard that gives you your access capacity and your volume. And you sit down and unpack and say, have we optimized our schedule? Have we optimized our slots? What is waste? And what does that look like? And what is the impact to our patients? How long is it taking them to get in? And so it's several measures that goes into your volume and goes into the strategy, but it starts with your provider capacity and then it moves on to your APP structure.
Yep, thank you.
Yes, sir.
The only, the thing that I would add that if you haven't considered that may be helpful is geomapping access and care gaps to understand other factors that may be impacting that and then tying that to capacity.
Yeah, absolutely. Thank you.
Dr. Irons, I had a chance to meet with you and your colleagues a few months ago about telehealth. So what role, or is there a role for telehealth in this initiative?
Absolutely, there is. So as part of the annual wellness visits, we are going to probably have some type of hybrid model with telehealth. But even with our regular provider office visits, I think we can leverage telehealth a lot better, and that is something that we're working on as well. So hopefully to have a little bit more information on that in 2 or 3 months.
No, I thought you were really open-minded about the conversation, so I appreciate that.
Okay.
Mr. Chair, the other thing on
Yes, sir.
telehealth I would say is there also may be an opportunity to look at what particular conditions or service lines might benefit from a specific telehealth strategy.
Yeah.
It could be a triage approach towards follow-up, but it's a way to get people connected, build relationships.
You're absolutely right. There are some service lines or specialties that are very amenable to televideo and telehealth visits, right? There may be others that are not, where they need to come in site on purpose, in person, but we will be looking at all of that, across the board to see that strategy of, how do we leverage telehealth based on the specialty.
Thank you for the information, all the work on this.
I want to recognize Dr. Green, who's participating remotely. She has a question.
More of a comment. I'm so excited about the virtual care telehealth initiatives that are going on. In addition to conditions that are amenable, certainly in this climate, there are also for, unfortunately, specific populations that may be that are definitely maybe amenable to virtual care. I think we have the opportunity to address some of the changes that have happened among certain populations, unfortunately, due to the current climate we're in. And I love that, and I'd like to just include that kind of in this space. I know that's something we're probably really thinking about and moving forward on it, but just congratulations on moving towards the opportunities to serve community through virtual care. I will also add that one of the organizations that has been successful in doing it have also placed looked at in their model of growth areas where they can bridge the digital divide, right? Because there still is that, and how they can offer guidance to people on options for bridging it. One of the options were having that a local hospital is now employing is having spots and kiosks and safe spaces where people can go within their community that they're comfortable going to access care if they cannot bridge the digital divide in their homes. So thank you all.
Thank you.
Okay, thank you, Dr. Irons, Octavia. Appreciate the presentation and the information. We'll stay closely in touch on this initiative. Thank you.
Thank you.
Thank you. I will add that also included in the CEO report, but will not be reviewed today, is the ARPA update. So please review that, and if there are questions, you can come back to Dr. McKitis or us to respond to those. Let's see, we will now move to item 8, and it doesn't appear as though the board will be going into closed session today. Thank you for confirming. So if there are no other questions or matters to discuss, we can move to adjournment of the meeting. Are there any other matters or questions? Okay. Having heard no questions or comments, as the agenda is exhausted, I'll declare the meeting adjourned. Have a good weekend and be safe with the weather forecast. Thank you.